Welcome, everyone. Thank you for joining us. I'm pleased to present Dr. Nicole Todd, who will speak to us about contraception and prescribing for midwives. Dr. Todd is a clinical associate professor at the University of British Columbia. You'll note that you can use the chat to the right-hand side of your screen to write down any questions that you might have, and we'll leave 10 minutes at the end for a question and answer period. Nicole, thank you for joining us.
All right. Good morning, everybody. Thanks, or I guess it's good afternoon. Thanks, everybody, for joining in. So I thought we'd give a little bit of a contraceptive update because there's some new options and some things to think about in setting of COVID. So I do have some financial interests with contraceptive products, but I'll be using evidence-based medicine to provide the best options for our patients. So we're going to first start off by understanding the SOGC's updated guidance during pandemics and periods of social disruption as it relates to providing contraception. We're going to review the CDC Medical Eligibility Criteria for contraception in the postpartum period. We're going to appraise research around mood and combined hormonal contraceptives, as that tends to be a hot topic. And then I'm going to talk about how the subdermal implant is now available in Canada. It was available in 101 countries, and Canada now is joining the stage. So please don't leave right now to get this app, but please screenshot this and get this app. This is a great point of care app for helping choose the safest contraceptive option for your patients who may be at risk of pregnancy. And so you can actually search by condition. So we may have patients whose mom has breast cancer, and where does that leave with the estrogen? Because a lot of times they feel that maybe they can't be on birth control pills. And so this app has nearly any medical condition you could possibly think of, and it's very easy to use. It's free. And so they often categorize things as 1, 2, 3, and 4. So 1 is you use it without restriction. 2 is you should sort of think that maybe there's an underlying condition that outweighs, or the advantages of not being pregnant and using it outweigh the risks of being on it. 3 is a condition which the theoretical or proven risks outweigh the advantages of using the method. And 4 is you absolutely should not use. So 4 is absolutely should not use. An example of that would be using combined hormonal contraceptives, the pill, the patch, or ring in somebody who has migraines with aura. 1 for IUDs can be used in nulliparous people, would be an indication there. And so you'll see that I'm going to use 1, 2, 3, and 4 when we start talking about contraception in the postpartum period. So what has COVID-19 done for our patients? Well, I can speak as a gynecologist. There's been a significantly delay of the surgeries, and we have a reduction in our access to diagnostic imaging, laboratory services, and even sexually transmitted infection screening. From a pregnancy care or family planning perspective, there's been a reduction in access to surgical abortions, although I can say our experience here in BC is we've actually had a rise in requests for that. But our patients may not have the ability to access emergency contraception or medical termination of pregnancy. Very early on, abortion care was deemed as an essential service, and so we can go to the ministry or any of our organizations to advocate that this be available for our patients. We know as far as contraception and is that there's a reduction in access to contraception, either that the patient cannot acquire prescriptions, such as the pharmacies are only dispensing 1 month of any of the hormonal options, which means multiple visits back, and sometimes there can be a back and forth between us as care providers and the pharmacy to ensure that that is ready. Same thing goes for mifegynemezo, in getting that from the pharmacies. And, when our offices are closed, patients obviously can't access contraception. And so early advocacy saying that contraception is an essential service. And so essential services deemed by the Society of Obstetricians and Gynaecologists is emergency contraception. So whether or not that is levonorgestrel only oral contraceptive or oral emergency contraception, ulipristal acetate, postcoital copper IUD insertion are all essential services. Any sort of IUD, IUC inserted for contraception, management of any IUD, IUC concerns, in-person contraception counseling for vulnerable groups where virtual care is not possible, post-abortion contraception, and then also making sure that we maintain access for virtual and online contraception counseling and services. So what is our clinical best practice with telehealth? You know, I think that a lot of us have learned how to work around sort of the new antenatal monitoring in the setting of COVID, but we can actually do a lot of things over the phone for our patients. So the following can be initiated without the need for an in-person assessment. So number one is the progestin only pill, which a lot of us would be familiar of as far as contraception in the postpartum period. Depo-Provera injection, and then combined hormonal contraception, so pill, patch, ring, ensuring that they don't have any contraindications. And so we need to complete a blood pressure once clinically feasible, but we shouldn't be asking patients to go to Shoppers Drug Mart or other sort of outpatient things. I do think one of the coming from COVID is that I think all of us need to be prepared in our homes with a thermometer, you know, a soap for washing our hands, but also a blood pressure cuff. And so I am advocating that my patients can do that, and I'm happy to write prescriptions to see if it can get covered for them. But we shouldn't be restricting access because we don't have a single blood pressure monitoring. And, you know, in the setting of antenatal care, we should have multiple options to look at. We need to also be ensured that we can have LARC insertion. So LARC is long-acting reversible contraception. So that's IUDs, IUCs, the energestrel releasing subdermal implant. Some people consider Depo to be a LARC, but we need to make sure that we're accessing this. Obviously, if we have any concerns about COVID risk in our patients, we should be delaying inserting at that time. So this may be important, pardon me, for your patients that are in their interpregnancy interval and wondering how long they can rely on this. So LARCs can safely be extended for up to 12 months in the following circumstances. If, I'm just going to use the trade name because it's easier to say, Mirena can be used up to 7 years in those who are greater than 25 years of at the time of insertion. So ideally, we're telling people that, you know, if you're over the age of 25, you can rely on this. We don't have as much experience with JDS or the Kylina, and so those people should be advised a second method of contraception until they can be seen for removal and insertion. Most copper IUDs can be used up to 5 years. If there's 380 millimeters squared, it can actually be used up to 12 years, and likely up till menopause if it was inserted after the age of 35. If you have any patients or clients in your practice that have the subdermal implant, you can delay that up to 12 months. So how are we able to help our patients? Well, this is where I hope that we can all come together here to improve access to contraception for our patients. So virtual, so we can offer virtual discussions this way or on the telephone and talk to our clients or patients about what the best option is for them, and then initiate that medication without actually the need to see them in person. In person, we need to continue to offer Depo-Provera and insertion, so IUD, IUS, and the subdermal implants. And my new thing is why not talk about this in pregnancy? So I think that we should actually be documenting a contraceptive plan for our patients in the third trimester, so that we can help them out, especially if it's going to be, if we anticipate there's going to be difficulties in accessing contraception in the postpartum period. Why not lay out a plan so that they either leave the hospital with the prescription or they leave the hospital with a contraceptive method already in place. Don't forget about seeking for coverage. So I can speak here in BC. If patients are enrolled in our medical services plan, and they can be enrolled in Fair Pharmacare, or if they're on income assistance, or if they're part of First Nations health benefits, it actually can cover some of our long-acting reversible contraception. So the WHO recommends that at least 24 months before attempting the next pregnancy to reduce our risk of adverse maternal, perinatal, and infant outcomes. We know for our patients or clients that have had a C-section, this becomes very important to ensure they have access to a trial of vaginal delivery with their next delivery. And so this is where we should be talking about this while they're pregnant and on those postpartum visits. So ideally, like I said, documenting between 24 and 35 weeks what the contraceptive plan is. So I'm sure you guys could run circles around me with breastfeeding and contraception recommendations, but I'm just putting the CDC recommendation update for 2016. So the CDC recommends exclusive breastfeeding up till 6 months and continuing on to a year. So ideally, we don't want to start any We don't want to start any combined hormonal contraceptives, the pill, the patch, or the ring, within the first 21 days. And that is merely based on your risk of getting VTE, so your risk of getting a DVT or pulmonary embolism. When you move to 21 to 30 days postpartum, it becomes a category 3. Remember how I said there's 1, 2, 3, 4? So category 3 is that, you really have to think, would a repeat pregnancy be catastrophic for this person? And if so, and no other method is acceptable, would you consider prescribing them this? And by all means, you're more than welcome to contact your local obstetrician gynecologist if you need further guidance on this. In the 30 to 42 days, it does bump up to a category 2, as long as they don't have any other risk factors. And then greater than 42 days, postpartum is a category 2. I guess one sort of caveat is, as with everything in COVID, it seems that we're having a shortage. So Micronor, my understanding is it's either not being manufactured anymore or not regularly being manufactured. So this is a time when you'd actually have to write the name of a generic. One name of a generic that I use is Movisse, Movisse, because when you write the name brand, sometimes the pharmacists are using it as a barrier to not providing contraception. And so you can just either write Micronor or equivalent generic on your prescription so that these can be filled for our patients. Oh, sorry, I should say that was Micronor. That's about Progestin only. Sorry. The birth control pills, there are some birth control pills that are in short supply. So one of them that we're experiencing here, or two of them that we're experiencing problems with in BC right now, is Seasonique and Brevicon. So it's just a matter of finding out what the pharmacies have access to ensure that we don't have any delays. So the current evidence is conflicting regarding the effects of combined oral contraceptives on breastfeeding. There's some low to fair quality studies that maybe demonstrate greater supplementation and decreased breastfeeding continuation in oral contraceptive users, but there's no perfect great study that we can use to base these claims. I think it's just a conversation that we have with our patients or clients. If they've had any problems with supply, I generally advise waiting much longer to start the combined hormonal contraceptives rather than starting it right away. There's no consistent effect on infantile growth, illness, or health outcomes. And so the CDC says we should discuss information regarding risks, benefit, and alternatives in women who may be at risk for breastfeeding difficulties, including previous history, medical conditions, perinatal complications, and preterm delivery. So what if they're not breastfeeding? So we wait for the first 21 days to avoid that VTE risk. And then after that, it becomes a category 2 in the 21 to 42 days, and then category 1 after 42 days. So I'm not sure if anybody has seen some of the discussion around combined hormonal contraceptives and depression and suicide. And so these are from large Danish cohorts of over 1 million people. So they are quite striking numbers when you initially look at them. They demonstrate a higher rate of first antidepressant use amongst combined oral contraceptive users, higher in adolescents. The problem is this is a database study. So it's hard for us to actually say that being on birth control pills causes mental health illness. Some people could say if you're already seeing a primary care physician or a practitioner for your birth control pills and they happen to ask you about mood, then are you more likely to disclose it because now you have a provider that's provided you with a treatment that's acceptable. So we don't have a correlation or causation. They did the same study, except this time only about 500,000 with the same database, and they said maybe higher rate of suicide attempts and completed suicide, highest amongst adolescents. But again, these are both database studies, and we need to have further research that's higher quality to actually find a correlation. So the SOGC in 2017 said there's no high quality placebo-controlled studies that demonstrate an increased risk of mood changes. You should discuss that there's a possibility of mood symptoms at initial and follow-up visits. And if a patient is suffering, then you should offer to switch them to a different one. A lot of people then ask me, well, what do you suggest? And there's like 28 or 29 different combined oral contraceptives available in Canada. I tend to stray away from the ones where the progestin is quite male hormone driven. So Yaz and Yasmin are anti-male hormone, or they're anti-androgen properties in their progestins. And Yaz is the only one in Canada that's actually recommended for people who have PMDD. All right, let's talk about postpartum contraception. So the immediate postpartum contraception is an effective way to improve your interpregnancy interval. So why not send our patients home with a contraceptive plan already in place? So our options that we can do on the postpartum floor are Depo-Provera, Progestin Subdermal Implant, IUC, and IUS. So immediate, so if you're within 30 days, Depo-Provera is safe, even when you're breastfeeding, and after 30 days, it moves to a category 1. If you're not breastfeeding, it's category 1. A lot of these have to do with those large observational studies that maybe increase a slight decrease in milk supply, but nothing is actually a great high quality study. The Progestin-only subdermal implant, same thing, within 30 days, category 2, and after 30 days, category 1, and not breastfeeding, category 1. IUD is levonorgestrel is IUD is category 2, just because they don't have as much high quality studies as we do with the copper. The copper IUD is actually used many places around the world for immediate post-placental IUD insertion, which we'll talk about, and so it's considered a very safe option. So what is postpartum IUD insertion? So PPIUD is inserted immediately following the delivery of the placenta or up to 48 hours. Ideally, we would like to have it inserted within 10 minutes of the placenta delivery. And we know that the benefit of insertion outweighs the risk of perforation and expulsion, or the risk of actually not being able to see us in follow-up to have these IUDs placed. So we should not be inserting IUDs between 48 hours and 4 weeks, because there is a documented increase in complications such as expulsion and perforation. We know lots of studies have been carried out using copper IUD and levonorgestrel releasing IUDs. More studies have examined the copper, and that's why it's a category 1. And just discussing with your patient cost and patient acceptability when you select your IUD type, see if they have any other factors that they'd want to control, like a history of pain with their periods or a history with heavy menstrual bleeding. So a PPIUD allows the women to leave hospital with a safe, effective, long-acting, and reversible contraceptive method already in place. IUDs have no effect on the amount or quality of breast milk. IUDs are safe in HIV-positive women. IUDs can be removed at any time with rapid return to fertility. Yeah, there's more advantages. We don't require any daily or weekly action on the part of the patient to be effective. So one of my colleagues who has children says, do you really want to, set an alarm for the one time that you're having a nap during the day to remind yourself to take the progestin-only pill? So this allows people to have a long-acting reversible option that they don't have to remember to take. There's actually a significantly lower perforation rate than the interval insertion, so that's the 48 hours to 4 weeks. And I do think that even less overall compared to when we do it in our offices after 6 weeks. You can see the lovely graphic there. It is very difficult to perforate a uterus with the ring forceps, as you see there. It also ensures rapid insertion of IUD because we know that they're not pregnant. And it's easier to access postpartum IUDs than post-delivery tubal ligation or bilateral self-injectomy. A lot of my colleagues are telling me that they cannot access this anymore. So the immediate postpartum tubal ligation used to be, on the same day that they had their baby, they would be consented either for laparoscopy or a mini laparotomy, and they would have the tubes ligated. But I have to say, at many hospitals now, they're no longer offering that. So what are the disadvantages? The main thing that this will be criticized is for expulsion rate. So it's got a higher expulsion rate than when you do put it in after 6 weeks. But that could be around 10 to 15%. Normal expulsion rate is 1 to 5%. But you have to look at it the other way. There's an 85 to 90% retention rate. How to offer it. This is a high yield resource. It's called the Global PPIUD Reference Manual. It is free, and I do not get paid by this, but the Mama U trainer is $60, easily accessible to your office. It's great. It's also great to learn different techniques as far as managing postpartum hemorrhage. And so that's actually how we uptrained everybody here at BC Women's Hospital. So let's talk about the subdermal implants, because they are here now, finally. And so it's a single rod progestin only, so etonorgestrel, 68 milligrams subdermal implant. It's a single use preloaded applicator, and you can find it on X-ray. The applicators are different than the ones in the past. So they think that the way that this applicator is made is that you're not going to get into trouble of the malpositioned implant that tends to migrate. It's effective for up to 3 years, 4 years during social disruption. And we know that what it has is reduced dysmenorrhea, pain from endometriosis, and anemia. The way that it achieves its contraception efficacy is it stops ovulation, it increases your cervical mucus, and it alters the endometrial line to make sure that it's thin. Okay, so this is the inserter here, and the whole rod itself is like a matchstick. It's 4 centimeters. So in breastfeeding, women, you can ideally time after the 4th week, but immediate insertion is supported by the World Health Organization, by the CDC, and the SOGC. We know that there are small amounts of etonorgestrel found in breast milk, but no impact on breast milk quality or quantity within the first 4 months, and no effect on infant growth and development. So how do we decide on helping our patients between all the LARC methods that we've talked about today? So IUDs, I think that the more IUDs you do, the higher success rate that you will be. And you'll be able to, I know that a lot of you already perform IUD insertions, and I think the subdermal implant insertion will be easy for you to learn. It is the first sort of surgical sort of thing I've ever experienced during COVID or any time in my career where we're actually learning virtually. So there are great virtual training sessions that are put on by Merck that help you gain confidence in offering this. We know that IUDs can be associated with more discomfort post-insertion and maybe a reason for removal. We know that the more common reason the subdermal implants are removed is spotting. So it's really kind of weighing those things with your patients. Both methods are undetectable. And like I said, the most common reason for removal of the IUD and the subdermal implant is bleeding. But both of them have very high ongoing use at 1 year, as high as 80%. There's a quick return to fertility. So as soon as you pull out the subdermal implant, you can start, developing your next follicle within, 7 to 10 days and potentially achieving a pregnancy, 2 weeks after having it removed. The same thing can be said for the levonorgestrel releasing IUDs and copper IUDs. It just depends what time of your cycle you're at as to when you remove them. So it's really about patient preference, knowing all of the above. There was a choice study, which is a study out of the US that said if cost was removed, what would you want? And a lot of people said they would prefer the IUD over the implant. But basically ask patients what motivates them for contraceptive choice and see if you can kind of help them arrive at a decision that best supports them. So we made it to this summary. So CDC Medical Eligibility Criteria for contraceptive use. The app is amazing. It just is. The unmet need for contraception increases during times of social disruption, and we need to ensure provision of contraception is an essential service. This is something that I fight for on a daily basis. Postpartum contraception should be discussed and documented with our pregnant patients between 24 and 35 weeks. We should really think about offering postpartum contraception. So we think that LARC should be offered as first line, and we know that the World Health Organization, CDC, and SOGC supports the immediate offering of contraception as depot, the subdermal implant, and the IUD in the immediate postpartum period, so before they get discharged from the hospital. We know that combined hormonal contraceptives should not be avoided in women with mental health history, but we should inquire about change in symptoms after the combined hormonal contraceptive initiation. So with that, I thank you. I'm happy to take any questions. I run a general obs-gyn clinic, a pediatric and adolescent gynae clinic, a heme-gynae clinic, complex contraception, bone marrow transplant clinic, a student health IUD insertion clinic. That is my email address there. It's also available PDF in your platform. And high yield resources, try and get the app, look at the SOGC guidelines. I know they're hard to get, but if you go into your university library search, you can find them that way. FSRH is out of the UK. It has great free articles similar to the SOGC. Bedsider.org is a great point of care counseling thing for our patients. And here's the link to both the PPIUD reference manual and also the Mama U trainer. So with that, I can take any questions.
Great. Thank you very much. That was great, Dr. Todd. So much good information and good references for our midwives to use. I just want to thank you for reminding us of that importance of looking for those generic brands that can be accessed, particularly during COVID, where some delays to access might be happening, to ensure that there's no, delays for our clients in receiving these. I wanted to talk a little bit more about, I had a question about the Progestin subdermal implants. I think this is probably the newest kid on the block for all of us here in Canada. And if you had some tips and tricks or just some sharings of your own clinical experiences regarding the use of this, also what types of side effects, if you are seeing any that are most common, that would be really helpful for me to just start to feel a little bit more comfortable, but also to beef up my informed choice discussions with clients.
Sure. So yeah, I think all of us in Canada are getting used to counseling and offering the subdermal implant. A lot of people who have experience dealing with patients with it are often people who've practiced outside of Canada. The most common side effect is spotting. So that's the main reason that people will take it out, is they just find that that's just too much for them. You know, you get occasional other progestin side effects like headaches or muscle cramps or bloating, but the majority of people are actually quite happy with it. It's different than the levonorgestrel releasing IUDs, because sometimes you release eggs or you're still ovulating on the side with the IUD. This one actually gives you kind of more of a level hormonal playing field. So you get not only the advantage of anovulation, but also pregnancy prevention. And, you know, as far as removing, I'd say in your office, only remove the ones that are easy, and there's great removal videos. If it doesn't come right away, send it to your local expert and just ask around to see who the local expert is, because the difficult removals can really be quite challenging. But for the most part, the new inserter is so easy that it is quite difficult to get it in the wrong plane, because it does kind of hold your hand at a level, like a parallel level, so you're not going to insert it in this sort of the wrong direction. People like it because it avoids a pelvic exam. So anybody who does not want a pelvic exam but wants long-acting reversible contraception, this might be the option for them. I always sort of say the depot, people have mood side effects. The problem with the depot is there's no antidote to it, right? And it has a longer return to fertility. This is still a progestin-only option. It's in the arm. As soon as you remove it, it's out of your body within 7 days. So that could be something that helps counsel people. We do not see the bone effects that we do with depot as we do with the implant. So it's just a matter for people who want to have a reliable contraception that they don't have to regularly think about, with a quick return to fertility. It's about $360 over 3 years. So technically a bit more expensive definitely more expensive than a copper IUD, but more expensive per year than the levonorgestrel releasing IUDs. I'm not sure why that came in that way. Here in BC, we're hoping the NDP have talked about pledging to fund contraception. They did that prior to the election, so now they have a majority. We'll see what happens. Keep an eye on us in BC, see what happens. But that could be another thing that comes into play. And I do find that more family physicians are opting, or like the idea of the implant insertion, because we had a lot of problems here with our college really changing the sterilization procedures and how they viewed the vagina, if you will, that it actually made inserting IUDs quite difficult for family physicians because they needed an autoclave. And even though we as obstetrician gynecologists sort of came up and said that no, we need actually to use evidence-based, it still is a barrier. So with the most family physicians do lumps and bumps clinic, and so thus they would have access to any of the instruments necessary for putting the implant in.
Right. That's wonderful. Do you see some of the mood disorder stuff that we typically see with the depot with the insert?
Not as much as we do with the depot. And I do like this one because you can actually, if there is a problem, then you can remove it, versus the depot, the mood side effects, if they're struggling, can really be hard, as it takes that 6 to 8 months to work its way out of the system.
Right. Yeah. So that shorter acting piece is really key there, in terms of if there were effects, being able to remove it quicker. We have another question in the chat asking, what do you recommend as treatment for spotting with an IUD?
Oh, I love this question. So there's a lot of funny things about using Nsaids and stuff. I don't use that. I think the more common thing that I do is the chronic pelvic pain people in Vancouver say you start with the progestins. And so they say that, you can either start with Provera, 10 milligrams a day, and you can try that for a month, or you can try norethindrone acetate, that's 5 milligrams a day for 1 month, or you can try Vazan. All of those are safe. You can use stuff in addition to the IUD, or you can give them, you can have them use a month of combined hormonal contraceptives, the pill, the patch, or the ring, and then you bring them back in a month to see. And so if they're still unhappy with the IUD, you can remove it, but at least now you have contraception that's on board. So those are kind of my main things. If it's more pain rather than spotting, I'll switch to the progestin, so either Provera, norethindrone acetate, or Vazan. If it's more of a bleeding, then I'll just give them 1 month of a birth control pill.
Oh, that's so helpful. You're honing us in. Thank you very much. That was just wonderful, Dr. Todd. I always feel like there's more to learn, and particularly as more things become available, as someone who has worked overseas and has seen the efficacy of the use of the implant. I'm just really excited to see that be part of some of what we can prescribe. So I appreciate you joining us and taking the time to be with us. And just as a reminder to everybody, there'll be more sessions live next Thursday on November 19th at 1 o'clock Eastern time. And the first session will be uncovering the history of Canadian midwives of color. So we look forward to seeing you all there. Take care, everyone. Bye-bye. Thank you, Dr. Todd.